Hey everyone, and welcome back to the second video in our oral surgery playlist. In video 1 we spoke about how to extract teeth in general, and in this video we'll talk more about how to extract teeth atraumatically. This is important because it preserves bone and soft tissue, reduces pain and complications, promotes faster healing, and improves outcomes for future dental procedures like implants. There are so many different ways to remove a tooth atraumatically and different schools of thought for what we should be doing. I'm going to be taking you through the technique which I found to be the most thorough and has given me the best results in my hands. This was taught to me on my implant course called Practical Implantology, which if you're planning to start your implant journey in the UK at some point, make sure you speak to me. I couldn't recommend this enough. Here's a quick summary of how to remove a tooth atraumatically, and I'll break this down and explain each stage. The only step that is missing here in this workflow, which was not required in this particular case, is the separation of the roots for multi-rooted teeth, which I'll be talking about later on in this video. First of all, when removing teeth, we need to remember that the tooth is not only encased by bone, but it's also attached by fibers. Usually we just skip the separation of the fibers from the teeth and go straight to dealing with getting the tooth out of the bone and forcefully tearing the fibers at the end while delivering the tooth. In reality, this can be damaging to the soft tissues around the socket, and so we should start by purposefully cutting the PDL away from the tooth. This can be achieved using a scalpel or a periotome. I really like starting with a scalpel because of how clean it cuts. I love this round scalpel handle, which was given to me by the Practical Implantology team because it gives me more control over the angulation. I personally prefer to use a 15C blade because it's finer and allows more delicate and controlled incisions. With regards to periotomes, these are actually sharp at the tips and can also separate the PDL from the tooth by walking the instrument around the circumference of the tooth. I like to use a periotome even if I've used a scalpel, just to make sure that there are no tissue tags still attached to the tooth. I bought my first periotome without actually knowing what it was. I just liked the look of it, and since then it's helped me in so many different sticky situations with deep fractured roots that I couldn't really get a luxator application point into, and so instead I'll use it to create an application point for my luxator in these more subcrestal situations. Although please note that this is the wrong way to use a typical periotome, and the likelihood of fracturing your periotome doing this is pretty high. But as you can see, this periotome is super strong and flexible. It's probably my favorite dental instrument right now. You can have a look at the description for a discount code on the Power Dental Group website. Once you've separated the PDL, you can now move on to separating the roots in multi-rooted teeth. The most efficient way to do this is with a speed increasing handpiece or a rear venting handpiece and a long tungsten carbide burr. This is assuming that the extraction is a non-surgical extraction, in which case you'll have a 1:1 ratio surgical straight handpiece with a Fisher burr, which can safely do the same job. Practically speaking, if you're not doing a surgical extraction, the obstacle of preparing equipment may deter you away from sectioning the roots, and so quickly using the former option would be way more efficient. The problem with using a regular turbine handpiece is that you will not have the option to turn off just the air like you would with a speed increasing handpiece, and so you'd risk creating a surgical emphysema. The problem with not carrying out this step is that you'll end up fracturing the roots somewhere unfavorable or fracturing the bone in order to extract the tooth. Both options aren't great, and more likely than not, you'll break a thin buccal plate of bone, reducing healing and bone height after healing. That means for all non-periodontally involved molars, I would section the roots. Now that you can deal with the roots one by one, you'll need to choose which root you want to extract first. I like to extract the straight roots first to give me more space for my curved roots to be extracted without the straight one being in the way. This selection process is mostly common sense. Sometimes you need to use the adjacent root as leverage to elevate another root though, so just keep that in mind. And sometimes you'll need to decoronate the tooth to facilitate the space to remove the roots. Once I've selected the tooth to remove, I always start with a 2mm straight luxator, working my way up in size until I have a good application point for my elevator, as explained in the first video about simple extractions. I would never luxate buccally, as this would break the thin buccal plate, and remember, the aim is to preserve bone. I would then apply my forceps with apical pressure and leave it to bleed for a few minutes. I usually use this time to write my notes. The process of pushing apically will expand the socket from the apical direction, and the blood pooling at the base of the socket will actually loosen the tooth. You can do this a couple times and then extract the root with ease. Now that the tooth is out, you need to inspect the walls and see if they're intact, which hopefully they are, and sometimes they aren't, especially if the patient had an infection preoperatively. You then need to degranulate the socket using a spoon end of a Mitchell's trimmer in the apical direction instead of a scooping motion from apical apical to coronal. Once the granulation tissue is at the apex, you can then scoop it all out. Also, you can use these amazing degranulation burrs before using a Mitchell's trimmer. You can get them from the Practical Implantology shop, and these burrs fit into your slow handpiece. You should be using it with water or irrigation to prevent necrosis of the bone, and you should be using it around 2000 RPM to prevent excessive bone removal. You'll need to disinfect the socket really well, and you can do this by mixing 50% betadine or iodine with 50% saline. You soak this mixture into some gauze and then you leave it in the socket for about 5 minutes. You can then use something like Blue M gel or Corsadil gel for another 5 minutes within the socket. If you're using Corsadil, make sure that the patient isn't allergic. At this stage, the socket will be really dry and you'll need to initiate bleeding again. You can get a small burr and puncture a few shallow holes into the apex of the socket to get it bleeding again. As always, remember, if you're close to the sinus floor, you never want to place apical pressure or puncture holes into it. At this stage, it's ideal to place a bone grafting material if you don't plan to place an implant within the first 3 months of extracting the tooth. This process can be called socket grafting or socket or ridge preservation. It's ideal if you want to maintain as much bone as possible, not only for implants but also for superior aesthetics for bridge pontics or denture pontics. It's only possible to do this without a membrane if the outer walls of the socket are intact, or alternatively if you use something like Surgiplaster P30 as your membrane. My go-to product for socket preservation is either a mixture of QOS from Ostem and Surgiplaster P30 from Gimas, or alternatively Physiograft by Gimas. I won't bore you too much with all the biomaterials information regarding this. I'm going to be making a whole separate video on biomaterials, and once it's out, I'll put a link in the description in this video too. Please know that these products can only be bought exclusively from the Practical Implantology shop. The team at PI have very generously given all our viewers 10% off all the products on their website, so make sure you guys go and check it out with the discount code TD10. That said, this is not a sponsored video, and on this channel, Zoe and I only teach what we apply and practice ourselves. Also, if you haven't done so already, feel free to subscribe to our channel. It really helps us grow and reach a wider audience. Back to the workflow. If you've placed the graft, you can then flatten a piece of hemocollagen and place it over the graft. And if you haven't placed the graft, you can stuff some pieces of hemocollagen into each root socket. An alternative to hemocollagen, because hemocollagen contains bovine, cow, some patients aren't very comfortable with using any cow products. You can use something like calcium sulfate in the Surgiplaster P30 packet, which is sold by Gimas on the PI shop. This can successfully act as a membrane, preventing soft tissue migration into your graft. You'll then want to approximate the soft tissues, ideally using a cross mattress suture or something similar. You can follow this video demonstrating how I do a cross mattress suture. There are a few different types of sutures that you can go with depending on the situation. You can choose from resorbable or non-resorbable sutures, different sizes, different cutting edges, different materials, whether it's braided or non-braided, whether it's monofilament or multifilament. I usually opt for a monofilament, non-braided, synthetic, non-resorbable, reverse cutting 4-row suture, which I remove 2 to 4 weeks later or once the knot has loosened, whichever comes first. There are many others that you can choose from depending on your situation. Then I protect my suture with the only plaster ever made for the mucosa, which is a South Korean product called AuraAid. With AuraAid, I cut and adjust the shape of it to match the socket by using some scissors prior to peeling the sticky part and then applying it onto the socket. Finally, I mix some Copac and place this over the socket as a final layer of protection to allow things to heal as well as possible. This stuff is horrible in the mouth and can either last an hour or a week, especially if there aren't any adjacent teeth for it to wrap around and hold on to. The best thing to do with this is mix a generous amount, place it in some warm water and mold it between your fingers. It's a good idea to put some Vaseline onto your fingers to prevent it sticking to them while shaping it. Get the patient to bite into it to make sure that you're not interfering with their occlusion, and once it's on, on, you can give the patient some post-operative instructions and let them go. This is actually just the tip of the iceberg when it comes to atraumatic extractions, but it would be really difficult for me to cover everything in one video. As time goes on, I'll make more and more videos and add them to this oral surgery playlist. Thank you so much for making it to the end of the video. If you're interested in bone grafting materials, granulation burrs, oral aid plasters, scalpel holders, and so many more products, please make sure that you go and visit the PI shop by following the link in the description, and don't forget to use our discount code TD10 for 10% off everything on their website. A little reminder that we've launched our own Shopify store too, with both freebies and paid products. As always, we try to make things as accessible and affordable as possible, and you'll find that products on the store reflect that. If you haven't subscribed already, then please do. It really helps our channel grow and reach more people. Thank you so much for watching, and we'll see you guys in the next video. Bye.